Shall I start?
Yes, please.
Yes. Hello, everybody. It's Claire Stevens speaking. I'm sorry we've had such difficulties on the phone this afternoon. So welcome to our urology webinar. We've got lots of people having to join on their telephones apart from their PC, so things will be a little bit difficult, but we'll press on through. Today we've got John Hines and Axel Bex with us, and welcome both of those to talk through Axel from the Royal Free, John from UCH, around for our urology pathway for today. If you want to share the first slide, Vanessa.
Yep, just bear with me for a
second. It flashed up for a second.
Yes, sorry.
So it's just an intro slide, and many of you will have seen it before, and it just explains about the North Central London Cancer Alliance. So we're an alliance which covers the whole of our STP geography, and that's just loading, I think, at the moment. But essentially, we're one of 21 cancer alliances in England, and we're all about improving early diagnosis and treatment, developing smoothest pathways for patients, supporting research development and championing innovation in practice and knowledge translation. So all of you are our partners, including patients, the trusts, all our practices, commissioners, councils and charities, and thanks very much for joining us this afternoon. So I think we'll move straight in to our presentation. Again, in a reminder slide for people, it'll be, you'll have seen, many of you will have seen it before. The thing to focus on is that yellow hatched area, which describes the shortfall in cancer diagnoses for us in North Central London, a shortfall of over 900 first treatments compared to previous pre-COVID years. So those are people that we have in our community, in essence, who have not yet been diagnosed and are probably not aware that they have cancer. So all that we can do to improve diagnosis is really valuable, particularly pertinent at the moment. So with that, I think I'll just move into our session for today. The housekeeping rules, again, you'll have met before. Please keep everything on mute if you can. Use the chat function, and this is to post questions, but if you want to attract attention, then wave, one of us will pick that up, or if you think that we haven't seen your raise hand function, please say. So thank you all very much. We're recording this session as usual, and you'll be able to access it later on our web-based channels. So let me pass over to John, who's going to give us that first primary care urology update, and then we'll move to Bex. Thank you.
Okay, thank you very much indeed. I'm going to talk, I hope, very briefly, about some prostate cancer and bladder cancer topics in line with what you just said, Claire, about innovation and stuff like that. So my next slide, please. So no talk about prostate cancer is, sorry, I'm very sorry, it's complete without mentioning PSA. Some time ago, I was the co-chair of the national team that wrote the National Prostate Cancer Guidelines, and when I did that, the PSA levels were slightly higher than they are now in the age-related range, but you can see what they are now, and I think everyone knows these. And the PSA levels have generally gone down, in terms of age relation over the years. So that means perhaps a bit more work, but it probably doesn't mean more biopsies now that we have MRIs, which are very good at picking out who should have a biopsy. And the next point I lifted from the North Central London Guidelines, in actual fact, about saying when we might do a PSA and what might cause a PSA to be raised. But I'd just like to highlight, it says there that rectal examination raises PSA. And if you do a very, very, very vigorous digital rectal examination and rub the prostate very hard and perhaps take a run up, it might make the PSA go up very slightly, but you should never wonder or worry about after a PSA, after a DRE. That's fine. Other things such as prostate biopsy definitely puts the PSA up, but that's clearly a secondary, not a primary care thing. So don't worry about asking for a PSA after a digital rectal examination. And by the same token, don't avoid doing a rectal examination because you want to protect a PSA. Because the next slide, please, explains why this is so important. So this is the positive predictive value of an abnormal rectal examination on black men and white men, and you can see the PSA ranges there on the left. So top of the range across the board is 4, but if you look at the first line, you can see that if your PSA is very low, between 0 and 1, but you've got an abnormal filling prostate, for a black man, there's an 8% chance they've got prostate cancer, even when the PSA is really low. So when you're doing your rectal examinations, you probably won't know what the PSA is, but you should still do it because there's still a very high chance you'll pick up prostate cancer if the prostate gland feels very suspicious. So please keep doing rectal examination. Next slide. So we now rely very heavily on MRIs. In 2014, North Central and North East London became, before we had alliances, and that was before the Vanguard, when we were, I don't know what we were called London Cancer then, but we were the first people to mandate MRI before biopsy. Now, I can't point to these 3 images, but this is the same multi-parametric MRI of a patient. And if you look at the middle image, they're all round things. That the rectum is the white thing at the 6 o'clock position, and above that is the prostate, and out to the left in sort of the in the 8 o'clock position there is a white thing that corresponds to 2 black areas on the 2 scans either side of that, and that is the tumour. So this multi-parametric MRI shows the tumour very well. So as I was saying earlier, we're certainly getting more referrals with slightly raised PSAs, but if the MRI doesn't show anything, the patient won't have a biopsy under many circumstances. So multi-parametric MRIs are now very important, and we're doing them more and more, and I'm sure you're aware of that. The next slide, please. The next slide shows a fusion of what the MRI shows and the ultrasound scan. So on the left is some abnormalities picked up on an MRI scan, and on the right is a transrectal ultrasound view of the prostate. Again, there are 3 images there. If you concentrate on the left of those 3 images, the very round thing towards the bottom is the transrectal probe, and above that is the prostate. The red area is an area of high suspicion. So that is a fused image from an MRI scan, so that when I did this biopsy, I knew exactly where to put the needle. And referring back to the grid reference, it tells you what the grid reference is. And then if you go to the other pictures again, the 2 pictures on the right, the red area is the lesion of high suspicion, and the green lines are the needle that have gone all the way through it. So we can now do very, very specific targeted prostate biopsies if you've got a decent MRI scan. Next slide. So the other person who unfortunately couldn't talk today was Claire Allen, and Claire's a consultant radiologist many of you will be aware of, and she's led a project that we started some time ago, the MIMS MRI project, and essentially over the years the MRI team have standardized the protocol for doing MRIs and what the report should contain, but there's still a problem with who should do the reporting and when. It's a big job doing the reporting. So we're just about to start a project. Claire is the lead of the MIMS project, and this is a cloud where MRIs done in any hospital in North Central London and North East London are uploaded and can be reported by whoever essentially is around to report. So in other words, there's always going to be someone somewhere who can report an MRI. So there will not be any waits now for MRI reports, and the people doing the reports are specially trained. So that means the reports will come through much faster, they'll be much more accurate, and this will allow us to do targeted biopsies. And then going back to what I was saying about not everyone with a raised PSA and an MRI will get a biopsy, with some double reporting probably. If 2 radiologists say there isn't a lesion, then biopsies will be avoided. So this MIMS project is going to take us forward in several big steps all at the same time, and is very important indeed. The next slide. So just to remind, everyone knows what the treatments are, I think, really, but for organ confined cancer, there's radiotherapy and surgery. Radiotherapy is the most common, but active surveillance is also very, very common, and not to forget HIFU and cryotherapy. So this is why we have our special clinic on Fridays at UCLH. At the moment, it's a hybrid, partly telephone and partly face-to-face. So we see our patients and they see a surgeon, they see a radiotherapist, and make decisions about what their treatment will be. Just to point out, the difference between active surveillance and watchful waiting is that with watchful waiting, we don't do anything, but we wait for something to happen. And this is usually in much older men where the prostate cancer is very unlikely to be a problem at all. And the thing that's changed a lot recently is locally advanced and advanced disease, which relies on oncologists rather than surgeons. And there are lots and lots of new treatments now, new hormones like enzalutamide and chemotherapy, docetaxel, which patients are now getting, and there are several trials going on. So in the good old days, we relied on hormones and possibly a radical prostatectomy and a bit of radiotherapy, and it's much more complex than that. And our MDT meetings and our clinics are now very multidisciplinary to make all this happen. But this is very much to the benefit of the patients. And in particular, you seem to notice patients with advanced prostate cancer are doing much better. So the next slide. So there's some things happening in the community. I'm not going to talk about very much at all, in fact, but we have some very good guidelines for stratified care in the community, and implementation is well underway. And most of North Central London is actually well ahead of North East London. But this is a big job again, and it's well underway. And the thing that's happening now in North Central London is the administration of LHRH injections, analogues in the community, which is far better for patients if a district nurse or a nurse in a primary care setting, a primary care nurse can give an injection rather than the patient having to come up to a hospital. So this is now work in progress. And the next slide. So just to say that we've revised now the bladder outlet obstruction pathway, so men with waterworks trouble, and just to point out that all these men will have a PSA, but when they get to UCLH, they're all going to have an MRI. So if there's any concern or worry about prostate cancer, they will be picked up. And we use MRIs now to plan benign surgery as well as cancer surgery. So this doesn't replace the 2-week wait referral, we complement it. So nearly all men with prostate disease now, certainly come to UCLH, are going to have MRIs, which will facilitate their treatment planning. Okay, next slide. And we're nearly there. I'm not going to say too much about bladder cancer, but bladder cancer is the other big tumour that I tend to deal with. And just to point out that 10% of hemature referrals have got transitional cell carcinoma. And John Kelly's been working for some time now on a point of care test for TCC in urine. And that will be a great advance when that's finalised, because it will be like doing a pregnancy test. And that will pick out nearly everyone with bladder cancer, and will mean we do far fewer flexible cystoscopies. We're now using MRIs much more in staging again, and recently there's been an increased use of hyperthermic mitomycin to treat superficial aggressive bladder cancer, which is a very good outpatient treatment, because a lot of the patients benefiting from hyperthermic mitomycin would have been having a cystectomy. And to move on to cystectomies, we're now doing more cystectomies on patients with aggressive disease, which is facilitated by robotic surgery. The outcomes are better, the operation is far less risky, lengths of stay are much better as well. And we now also try and push chemotherapy before surgery, because this confers a 10% survival advantage. So there are things going on across the board in bladder cancer, again, for the benefit really of outcomes. And I'd say this is one of the benefits of having such a large Pelvic Cancer Centre at UCLH. There's just 2 more slides. So this says prostate at the top, and this is some research I did about 4 years ago, and these are databases that I was able to interrogate using some software written by NHS England. And if you apply that, next slide please, to men in a prostate pathway. So this goes back a bit, 2014, men with prostate cancer in 10 trusts in North Central, North East London. And the 0 line is the diagnosis, and above it are events from the diagnosis, but below it are events that happened in primary care mostly that might be related to their prostate cancer. And this was very interesting to do, but we don't really know exactly what causes prostate cancer, but we do know lots of things that cause bladder cancer. And so we're now just going to start using, one of my students who I'm supervising their thesis is now going to start using this software to interrogate things that happen to patients before their diagnosis of bladder cancer, to see if we can pick things up first. And as a preliminary, we're already picking up a very high rate of urinary tract infections years before they present with their bladder cancer. So this is just our ongoing research to give you an idea of what we're doing. Thank you very much.
Thanks very much. That's great. Thank you so much, John. Let's move straight to Axel, and then we'll take, I think, questions later on at the end. So just mindful of time. Thanks, Axel, for joining us today. Not sure if we can hear you. I think you might be on mute.
Yeah, that's right. I would need my slides up.
Yeah, so we've got them there, I think. We can see them. Can you see them?
Yeah, I hope I got the title and the topic right. So I thought I'll discuss a little bit about the early diagnosis of kidney cancer and the importance of imaging it plays in this role, and how we see them here in our pathway in North London. So next slide, please. These are my disclosures. I'm also part of the vice chair of the European Kidney Cancer Guideline, and may therefore make some recommendations about treatments. Next slide, please. And let's go right into the topic here in the UK. Kidney cancer is basically diagnosed in about 13,000 patients a year. This is roughly about 4% of all cancers. And interestingly, when I was in education, the peak, or the age peak, would be around 60, 65. This has now gone up to 85, 89, so definitely octogenarians. And what is also very interesting to see is that there is an incidence increase of kidney cancer by 87%. And that is very interesting. If you look across other countries in Europe, that is not happening in parallel. In some Northern European countries like Scandinavia, Sweden, the incidence is actually going down. In others on the Balkan and Eastern Europe, it's still increasing. So we do see some differences here, but by and large, this increase is still notified. Next slide, please. If you then look at kidney cancer incidence in the UK by gender and age groups, so it stopped in 2017, and the fact that the curves go a little bit down at the end doesn't mean there is a decrease again. It's just it has something to do with the statistical methods they used. But what you can see is that males are more affected than females. Now that is something which is already known. And on the right-hand side of the slide, you can see what I just alluded to, that there is actually a peak in the octogenarians. Now, this is very, very interesting because we also see that at our SMDT discussion. We discuss on a yearly basis about 4,000 patients in our multidisciplinary tumor board. Now, about 1,000 of them might be new referrals. A quarter of them are 2-week wait referrals, and many of them are actually octogenarians. And I think it is important for you to know that if these masses are small renal masses, it is actually of very, very little consequence. And there are some retrospective data out there that suggest that if you are above 70 and being diagnosed with a 2-centimeter solid mass, you may probably as well leave it alone because it may not harm your physical well-being. Next slide, please. This is a slide I'd like to remain a bit longer. This is the proportion of kidney cancer cases diagnosed each stage, and this is all stages. As you can see on the left-hand side, there are these graphs. Basically, the small renal mass is stage 1. Might as well enclose the ones which are a little bit bigger than 4 centimeters, up to 7 centimeters in size. But basically, the classical small renal mass defined as up to 4 centimeters is hiding in this group. And you can see that about 40% in the UK, well, this is broken down between England, Scotland, and Northern Ireland, but let's take them together for the ease of the talk. So what you can see is about 40% of them are being diagnosed at this early stage onwards. And you see in other countries where there's a more widespread use of imaging due to their healthcare systems, which may be a bit more different than the NHS. So there's a range of differences. In some countries, this is almost up to 60%. In most countries, it's in between 40 and 50%. But what you can also see is that there's still a considerable number of patients that are being diagnosed at stage 3 and 4. So stage 4 is systemic disease with metastasis at other organ sites or growth into adjacent structures, which is T4. Now, this has gone down. When I was in education, so let's talk about the late 1980s, early 1990s, this was 1/3 of all cases being diagnosed. And in Scandinavia, the figures from 2015 suggest this is now only 10%, and the Netherlands and the United States is 18%. So the UK is a little bit higher than that, but it reflects the general trend. Next slide, please. Now, the classical triad, as it used to be, like patients would present with flank pain, hematuria, palpable mass, that was still the most commonest way of presentation in 1971. There's one publication I found, but this has really changed. So in the past, 66% or 2/3 of these patients would already be metastatic at diagnosis who present with this triad. And we see them nowadays in only 10% in most countries in the last decade, which is again a testimony to the widespread use of imaging. And that's the next slide, please. We all believe that it has to do with this. There is an increasing use of imaging. It's not used on purpose to diagnose kidney cancer, but most of these tumors are actually found incidentally. So you can imagine that patients come in for other problems. They're either on follow-up for other cancers, or they had a trauma, or they had some abdominal discomfort, whatever, which may be completely unrelated. There may be some sort of ileus symptoms, bowel obstruction, may actually lead to a completely different diagnosis. But then very often we find these small renal masses, which are defined as up to 4 centimeters in size, as I already said. And patients are then referred for further diagnostics. There are also, in some countries, there are screening programs ongoing. And I know in the Netherlands, for example, where I used to practice before, it's not allowed by law, but you can go to Germany, pay for a CT scan, for example, and come back across the border. And we will briefly discuss this topic later on. Next slide, please. Now, the overall clinical presentation, it's very difficult to find recent data on that. And they may differ per healthcare system, so we have to take them with a grain of salt. But if you just look at the clinical presentation, so as I already alluded to, 33 to 40% of patients are probably being diagnosed with these incidental findings. You wouldn't know they have them unless some imaging is being done. Patients have absolutely no symptoms. Some patients present with hematuria, others with abdominal pain, others with a lump, and as I already alluded to, taken together, this would be the classical triad, but this is currently fairly rare. And they can also present with symptoms from metastasis, and we'll touch on this later. But I think when we look at primary care, and that is very, very important, we should also realize that very often kidney cancers present actually with a sort of paraneoplastic clinically available parameters. Roughly half of the patients present with an elevated erythrocyte sedimentation rate, or C-reactive protein nowadays. Some have polycythemia, hypertension, hypercalcemia. This all has to do with paraneoplastic substances that look like, for example, parathyroid hormone or other angiotensin angiotensin-converting enzyme, and are then related to these symptoms. Anemia is fairly often seen, and you can also have deranged liver function test. And taken together, if you do have patients like this who feel fatigued or just a lack of energy, and you find some of these findings, then you should actually think about a possibility. I admit this is rather unspecific. Next slide, please. Primary metastatic disease, as I already said, is not the most common presentation nowadays. Sometimes it is obvious, like in this slide here with a scalp metastasis. There's a lump which is hard, but most metastatic sites are actually asymptomatic. Although I have to admit, I was a little bit surprised, and John may be surprised as well, that in a large nationwide inpatient data set from the United States, about 12,000 patients with metastasis, bone mets came in second. It's almost like prostate cancer, you would say. So 30% of all metastatic sites would be allocated to the bone, and these can be painful, or they can fracture with pathological fractures spontaneously, and then patients come to diagnosis. The other lesions that are typically symptomatic very early on are brain mets, but they only present with 8.1% of all metastatic sites. So again, here you can be fairly advanced metastatic without having any symptoms. And that is also why kidney cancer is known as a clinical chameleon. And it is much more common to actually present with fatigue and weight loss, which is a typical story. Patients said, doctors, I lost 8 stones unwanted in the last 2 or 3 months, and I feel completely exhausted. Now, this is a typical story, and then they might not even have reported hematuria. Next slide, please. There's also one of the reasons why I borrowed this slide from a befriended colleague from Cambridge. They're investigating if screening may make sense. You see a couple of variety of tumors here. Kidneys in the middle, that's this pinkish tumor site. Again, here we see this distribution of the small renal mass, and then the stages 3 and 4. And next slide, please. That is, it doesn't move forward, but so metastatic cancer can only rarely be cured. And in 40%, as I said, 40 to 45%, we still have these larger stages which are either at risk of further progression or are already metastatic. So there are some concepts to look into screening. Next slide, please. They actually calculated that the incremental cost effectiveness ratio, when we look at the costs per quality of life years gained, might be competitive for male patients at the age of 60 years with about £18,000 yearly, if you would do that. And that might actually be cost effective when you look at the life years gained, but also at the costs of treatment. We do know some of these results from ongoing screening studies for lung carcinoma. We frequently see patients being transferred from screening programs for lung cancer or for aortic aneurysm, where these little lesions are being picked up. Next slide, please. So in the sake of time, let me conclude. I think I made clear that the incidence of kidney cancer in the UK is increasing, not dramatically, but it's going up every year. There's an increase in incidentally diagnosed small renal masses that comes with the use of imaging. And there is, thankfully, a decrease of patients diagnosed with primary metastatic RCC. We believe that it has to do something with that. So if you diagnose more small renal masses, then at the other end, you probably have a decrease in these fairly advanced tumors. Although it would be unlogical to think that every small renal mass progresses to a metastatic disease. Yet 40% of patients still present with stage 3 and 4 kidney cancer, and the classical presentation is nowadays rarely seen. I think it's important to remember that small renal masses are almost entirely incidental findings on other imaging indications, while primary metastatic disease is more likely to present with non-specific symptoms. Thank you very much for your attention.
Thank you, both of you, very much for two really interesting talks. So can we just go to questions? I've got a question from Imogen Blore in Islington, GP in Islington. Imogen, do you want to say your question?
Yes, I suppose, I mean, I find the urology guidelines very helpful. But I struggle a little bit with particularly the non-visible hematuria one. And I've struggled with several patients recently because if you follow it, the logic is that in somebody under 60 with persistent non-visible hematuria, the only imaging you're doing is an ultrasound KUB, which isn't going to pick up a bladder lesion. So the implication is that people under 60 with persistent non-visible hematuria don't have bladder cancer, but my little reading around it is that isn't the case. So I'm slightly confused by the logic, and at what point are we just waiting for the few that might have a bladder cancer to develop frank hematuria? I'm just not quite sure where we go with that, and at what point we think, don't feel entirely happy. Don't know if there's a simple answer to that, but it's just the one I struggle with most.
Thank you.
John, do you want this, or shall I?
John's frozen. I'm not sure whether he can. So, can you take it, Axel? Thank you.
Yeah. First of all, I think it is very important to realize how these guidelines are being made. I'm not sitting on the hematuria panel, to be honest, which doesn't mean I don't feel responsible for them. I sat on the Dutch hematuria guideline panel, and there actually the age group is lower. So we decided that should be 45. And if it's persistent, so I think it was just the idea, if they're younger and it is just a one-off, then you just see them back. But if it's persistent, then you should escalate the imaging. You would start with an ultrasound, and then depending on the patient's history, then also contrast medium studies could be done. So I think at the EAU, very often they work with level of evidences, and it is very important to know how this came about. Could be that it was done with systematic reviews. I actually don't know of any very good studies that have been performed that would clearly indicate a definite age threshold. And I think it's a decision then of that team where you would put that age threshold.
Thank you. Yes, John, we've got you back now.
Yeah, sorry.
Thank you.
So, Axel, thank you very much. That was very helpful, actually. Guidelines are guidelines, of course. And if you have a worry about a patient, just please send them to the 2-week wait hematuria pathway. The imaging we do is intended really just to look at the upper tracts, look at the kidneys, and we do a flexible cystoscopy to see what's going on in the bladder. And every hospital does it a bit differently. At UCLH, you're going to have very often now a very low dose CT without contrast. There's a new scanner here. There's virtually no radiation, they tell us. And a CT without contrast is very, very fast, better than an ultrasound. And then if we see something, you get whatever imaging is required. For advanced bladder cancer, we're doing more MRIs. And in particular, so the reason I'm doing this research that I showed you earlier with Public Health England and looking at what happens to patients before they present is women present a bit later than men with bladder cancer because they have lots of other reasons for their symptoms, like infection and stuff like that. That's what we're looking at. So if you're worried about someone and you can't put your finger on why they've got hematuria or why they've got their voiding symptoms, just send them along because we can sort it out.
Okay, thanks.
Thank you. Thanks. Can I just extend that discussion a little bit? How we've used the words persistent hematuria across both here in the UK and in Europe, Axel. How many times over what time period would you like us in primary care to be having in our minds when we're thinking about persistence?
Yeah, good question. I think we defined, and in the Dutch guidelines, we said, for example, if someone's below 45, presents with microscopic hematuria, which is not related to nephrogenic hematuria. So, for example, that they may point towards glomerular disease, then we would probably, and there's no other sign of infection, for example, urinary tract infection, then we would probably see them back within 6 weeks.
Yeah.
That was the recommendation. To make it practical, you may want to see them back within 2 weeks or 3 weeks, but I think if on 2 occasions you have persistent hematuria, for me that would be a warning sign. It's like what John said. It's a guideline, and there's always this thin, precarious balance between doing too much diagnosis and too little. And a lot of these can also be understood by healthcare systems where imaging is done by radiologists, for example. You also have healthcare systems where imaging is done by urologists, and they would very probably just use an ultrasound and look at it, and they don't understand why there would be that that structure that you first have to think or have to have another threshold of.
Yes. And in terms of primary care, one of the challenges that faces us, thinking about renal disease particularly, both of you, is of course which bits of imaging to do before referring up. We've talked about ultrasound, but during COVID, ordinary direct ultrasound has been extremely difficult for GPs to get, and for many, many months they weren't allowed to request them at all. What is now coming back particularly is the provision of using being able to request imaging exclusively for exclusion of cancer, and that's on a different separate form that we all have now on our computer EMIS systems. But at which point, do you want to highlight the sorts of symptoms or signs that would trigger you wishing us to do a direct access urgent imaging as opposed to the 2-week wait referral in the first instance? And secondly, on TQuest, just so that you're aware, we have the option to request ultrasound, but we also have an option to request CT renal imaging, although it's a bit difficult to predict how long that will take to come through from a primary care perspective. So those 2 questions. Thank you.
Yeah, I think maybe let's start with the last one. First of all, when we discuss patients at the SNDT level, we can only take a decision on how to treat them for their management if you do have cross-sectional imaging, which is triple phase. And also for some more advanced stages include CT chest. Now, if it comes to diagnosis, I think a lot can already be won just by ultrasound, and then you can take it from there, because all you want to know is that in your differential diagnosis or not. And I think what should trigger urgent ones are, again, although that's quite rare, but you don't have to have the classical triad, but any of these symptoms. So either abdominal discomfort and palpable mass, or flank pain, palpable mass, and hematuria. So any of these 3 symptoms, I think, should trigger it. The downside of this is, as I already said, kidney cancer is unfortunately a silent killer. If it can be 7, 8, 9 centimeters in size, you wouldn't know you have it. Therefore, I think if in the laboratory assessments you have a very elevated CRP, for example, or ESR, and the patient suffers from weight loss. So this is a general oncological warning sign. It's not typical for kidney cancer. It can be any cancer. And that should trigger, in my point of view, at least imaging that could be directed at kidney cancer, but might include other cancers as well. Certainly, if there are no other leading symptoms, weight loss, fatigue, and an elevated CRP, that is almost a classic.
Thank you. There's a question that's come in again from Imogen. When would you order transrectal ultrasound for prostate assessment in primary care?
I wouldn't.
You would not, right?
Well, I think so. So it depends what you're looking for, really. But transrectal ultrasound gives a fairly good indication of size of the prostate. But the size of the prostate doesn't relate to symptoms. Yeah. The size of the prostate doesn't relate to cancer. And it's an invasive procedure that is not well tolerated and probably doesn't take you very far.
Okay. Thank you. So that's really what you're saying is it's difficult to find a reason for us to have it on our menu of tests at all nowadays.
I think a rectal.
That's fine. It's just asking. Yeah.
Yeah, no. And then that leaves more time to do the tests that are important.
Yeah.
Right.
Yes.
imaging. Yeah.
Yeah. Okay. Now, I'm presuming, just for the sake of clarity, Axel, when we were talking about if one found a palpable mass, one would be wanting to do a 2-week wait rather than the urgent imaging referral. Just wanted to clear that up for our the attendees today. Or do you feel that the 2-week wait, the urgent request for imaging, which would perhaps return an image on the 3rd week, would be quick enough? Or I think most people attending today, if they found a palpable mass and were worried about the abdomen or the urology system, would tend to go straight to 2-week wait referral rather than hold the person in primary care for 2 to 3 weeks for imaging.
Yeah.
Are you agreeable, both of you, on that?
Yeah, I would agree. Yeah, you're quite right. I mean, good thing from the point of view of timeline. There are very little data out there, but kidney cancer does not behave as aggressive as bladder cancer, for example. So anything that is done within 3 months will probably not change the prognosis of the disease. Obviously, as a patient, you want to know what you have and what kind of management is important, but it is also not as urgent as, for example, acute abdominal symptoms.
Yeah, thank you. I've just posted in the chat if anyone wants to ask any other questions. We've got sort of 2 or 3 minutes before we end, or wave a hand. I can't see any hands up at the moment. For both of you, are there particular other messages that you want to give to, or give to the group, or questions you want to ask us, as we've got lots of GPs on the call today?
I don't think I have any questions. I take part in the Pan London group. There was lots of concern at the start of the pandemic about should rectal examination be avoided because it might produce a coronavirus spray.
Yeah.
Which it doesn't. We don't think now. So please carry on doing rectal examinations. Okay,
thank you. And that slide that you showed us was really helpful, John, around very low PSAs but abnormal prostates. So that was helpful. Okay, thank you both very much. We really appreciate you coming. I'm sorry that we've had an MS Teams issue today and people found difficulties getting on, but it's been really helpful. We've recorded the session so people will be able to access it later. Thank you very much, both of you.
Thank you very much, everyone. Thank you. Bye.
Very much.
Bye-bye. Thanks also to our team.